So high-resolution micro-ultrasound going beyond MRI. Let me just begin by asking how many people here are familiar with high-resolution micro-ultrasound, have used it? So it looks like maybe, I don't know, 20%. So this is the real deal, and Dave and I agree about this. I have had research support from Exact Imaging. I have some favorable bias about the technology. It was invented by the imaging research group at my hospital at Sunnybrook in Toronto. And my personal story is that I had a lab for my whole career, and I was mainly studying orthotopic prostate cancer in mice, which are, sub-millimeter tumors. And I heard about a group upstairs in the research building that had developed a microscopic ultrasound where you could image 500 micron tumors. You could image in a living mouse a tumor less than half a millimeter. So I did a bunch of studies tracking the growth of these tumors with microscopic ultrasound, and I never thought this would pan out into anything of clinical use. I mean, what's the value of finding a half a millimeter tumor in a human? But they had greater vision than I did, went on to develop this device. So just a bit of background. For 30 years, we've been doing systematic biopsies. That's obviously moved to imaging mostly with MRI. And I think it's well known that conventional ultrasound is good for visualizing the prostate volume, but not for visualizing cancer. You can see large cancers with conventional ultrasound, but they have to be large and obvious. The main purpose is to guide the biopsy needle, but we still rely on conventional ultrasound for the biopsy, even in the men who have the MRI with fusion targeting. So MRI, we've been hearing a lot about it. It's an incredibly powerful tool, but it has important limitations. It's not real time. It requires specialized training. There's artifact induced by treatment. It misses small lesions. We heard about that data yesterday. There's cost, complexity, access, claustrophobia, incredibly common. I don't really understand that, but I see it all the time in patients. Pacemakers, hip prostheses, et cetera, contraindication. Lots of places in the world, including Canada, have inadequate access. This is just one study from UCLA, Rob Reiter's group. The bottom right here shows in patients with multifocality, something like 80% of small significant prostate cancers, grade group 2 prostate cancers, are missed. So it has limitations. It underestimates size by about a third on average. And here's one study from Sloan Kettering that was in men on surveillance that showed that stability of the MRI did not translate into grade stability, and that about a third of patients who had a stable MRI nonetheless progressed to grade group 2 or higher. This is a study, a randomized study we did a few years ago, comparing in men on surveillance systematic plus targeted to systematic biopsies alone. This study was designed to be positive. Of course, you throw in target biopsies, you're going to find more cancer, but we didn't. It was a negative trial to our disbeliefs. Some of the worst data that anyone has ever published about the performance of MRI, which I'm kind of proud of, because I think it tells us something about the limitations of fusion-targeted biopsy. This was with the Artemis device. And in retrospect, we were on a learning curve. We just didn't realize it. But this just shows we had the PIRADS 5, only 1/3 of them had significant cancer, whereas here's the precision study from UCL in London, 80% had significant cancer with PIRADS 5. So, Houston, there's a problem. And so it's not perfect. Huge tool, but not perfect. So this is where micro-ultrasound potentially has a niche. So the difference between micro and conventional ultrasound mainly is the frequency, 29 megahertz compared to 6 to 9 for conventional ultrasound, which means the resolution is 3 times higher, 70 microns versus 200. 70 microns is the diameter of a prostatic duct. So as cancer increases in grade, loss of ductal anatomy is the key characteristic of higher grade compared to low grade cancer. You lose the ductal anatomy. It's just like the principle behind diffusion weighted imaging, and you see loss of this speckled pattern, which is the main feature of cancer. and pretty short learning curve for people who are experienced ultrasonographers. It kind of looks like a conventional ultrasound device. There's some other differences too. The packing of the crystals is much tighter. So there's been a number of innovations that allow for this very high resolution and yet still maintain fairly distant field imaging. The downside of higher resolution is you get less penetrance, but they've more or less solved that problem. So here's conventional. This is the large setting, which is really consistent with usual ultrasound. And here's what you see with the high resolution. And you see this kind of speckled pattern like Havarti cheese. And loss of this pattern is the key feature of cancer, although there's a number of other cancers. And with the current iteration, the maximum distance you get is 6 centimeters from the rectum, which covers the vast majority of even very large prostates. So I mentioned crystal spacing also increased compared to, which gives it some of that properties. You can use it with transperineal, which is what I do. There you can do it with this transperineal guide. You can use a template. It's quite adaptable. And this just shows some of the things that you see that are not so obvious with conventional ultrasound. Some of these patterns like bright echoes, smudging, there's something called cauliflower appearance. You can learn to recognize these quite rapidly. You see the anatomy very clearly. You see alterations. There's neurovascular bundle. You see alterations in the prostate capsule very distinctly. It's really quite comparable to MRI. This is the Primus protocol. Probably most people have heard about this by now, and a number of these patterns. And there's data that if for someone who is experienced with ultrasound, it takes something like 15 to 20 cases to learn how to recognize these abnormalities. What takes longer is what I call the specificity learning curve, meaning you start to look at small equivocal lesions, say, I've biopsied enough of those to know that I don't have to go after that one. That takes a couple of years, but the more important one is the sensitivity learning curve, learning to identify these abnormal images quite quick. And you see needle tracks, and this is 5 years after a biopsy, they're still apparent. And this just as an example, this is transrectal. There's the lesion. You would probably have seen this on MRI, and then you hope your fusion targeting is accurate. It wasn't in the randomized trial we did. And then here comes your needle. But the thing I just want to emphasize is there's not much likelihood of a pathologic miss. That needle has gone through that lesion. So you have the confidence that you actually see what you're hitting. There's the lesion there. There's the transperineal biopsy. And you can see where your needle is going relative to this actual lesion. Here's an anterior transition zone cancer. And this is, again, a transperineal biopsy. And, this would be potentially tricky with either fusion targeting and particularly with a transrectal approach. So I'm an advocate of transperineal biopsy. That's a whole other discussion. And here's some of the early data. This was a publication of mine, the first 11 sites to start using this. This definitely reflects the learning curve. This is a registry. It's not the greatest data. Not every center blinded themselves to the MRI, but certainly in this early experience, the sensitivity was actually better than MRI, certainly not worse. The specificity was about the same. And now there's a lot more data. So this is from Milan, Giovanni Lugazzani, who's been one of the leaders in this field. He really embraced this whole technology. So here's for each score, PIRADS 5, PIRADS 4, and Primus 5, Primus 4. You see the predictive value for significant cancer is really comparable, all the way down to negative as well. As I mentioned yesterday, what is the implication of ultrasound negative compared to MRI negative? Probably similar, but there's no genomic, sort of ultrasound genomic data that's come out yet. This is some more data comparing MRI to ultrasound blinded, scrupulously blinded, and you can see that about 60% the lesions were seen on both modalities. In about a quarter, it was only seen on ultrasound, and about 15% only seen on MRI. So this just reinforces the message. These are, it's not like MRI versus ultrasound. They're complementary. They both add something, in my opinion. And this is the role of micro-ultrasound in the PIRADS3, which are the lesions we all grapple with. Like, what does it mean? In my opinion, PIRADS3, the data is that it doesn't really move the needle in terms of risk. It's as if you hadn't done the MRI. Some of them are positive, some negative. But if you do micro-ultrasound, it's negative. It's got 100% negative predictive value in PIRADS3 for significant cancer. Not one patient had a significant lesion. And in contrast, if it's an obvious lesion on micro-ultrasound, a very significant proportion had significant cancer. So it's got a role there in complement to MRI. How do these compare in the diagnostic pathway? The company is funding a fairly audacious trial comparing patients with MRI before biopsy to micro-ultrasound to the combination. Over 1,000 patients. This study is accruing like mad. It's going to complete successfully probably within a year or so, and we should have some robust phase 3 data on how these compare in terms of diagnostic accuracy. So to conclude, and I see that I am on time, against all expectations, it's got a lot of appealing features. It's one-stop shopping. Particularly if you do transperineal biopsy, the patient does not need antibiotic prophylaxis beforehand. They come in, they have the ultrasound, the lesion is there, you biopsy it. The patient doesn't have to come for an MRI and then come back to have the targeted biopsy. It gets around that whole fusion targeting technology, which is an advance, but which also has some, poses some sources of error. It's inexpensive compared to MRI. It's the entry to get the ultrasound is comparable in terms of cost to other kind of high-level ultrasound devices. I think something around $200,000. It's appealing in resource-constrained environments as far as MRI, which is actually most of the world, and I would include Canada in that. So all these patients who would otherwise be waiting 6 months for an MRI with their elevated PSA can get a micro-ultrasound right away. And it's also urology driven, this is now pure bias, but it brings imaging of prostate cancer back into the urology domain, and there's a lot to be said for that, in my opinion. So I have really incorporated this into my practice. Elevated PSA, they get micro-ultrasound. My order says ultrasound plus minus biopsy. If there's a lesion there, I biopsy it. No lesion, no biopsy. I talked yesterday about how I feel about the basis for that. In men on surveillance, I alternate back and forth every 2 years or so. If they're stable, they get an MRI. 2 years later, they get a micro-ultrasound. And there's the patients in whom the MR shows a lesion, but you don't see it on ultrasound. I do cognitive targeting. But that doesn't come up too often because somewhere around 85–90% of the time, if you see it on MRI, you see it on ultrasound. Thank you very much.